Hello, welcome you all to our next important session, that is the short rheumatology flashcard. In this series of lectures, we are going to have a discussion about a rheumatological topic very briefly. Okay, so without any further delay, let's go back to our case scenario. A 67 years old man admitted to the medical ward with a complaint of pain, stiffness, and swelling of the hands, which has been presented for the past 2 months. On further questioning, the patient reports about mild weight loss and fatigue. He reports occasional difficulty in passing urine and nocturnal urination. In the recent days, he had 2 falls at home because his knees just gave away. Okay. Now, on examination, there is tender diffuse pitting edema of the fingers and dorsum of the hand, which is bilateral, as well as there is synovitis involving the small joints of the hand as well. And active and passive movement of the wrist is so painful. There is no neurological deficit in examination of the upper limb and lower limb. Okay, there is no localized tenderness on palpation of the spine. So the concern is that on history, the patient is having pain, stiffness, and swelling in the hands. Also, he is having some urinary complaint. Okay, and he also have some diffuse pitting edema involving the finger and dorsum of the hands, okay, which is bilaterally alongside of the synovitis. Okay, whenever we're dealing with the synovitis, particularly involving the small joints of the hand, we are suspecting that it might be a case of rheumatoid arthritis. Okay, okay. So now just look at the investigation. Hemoglobin is 100. Okay, total leukocyte count increased, and there is significant amount of neutrophil is increased. Okay, platelet is okay, it's normal. The CRP is significantly increased as well. Okay, and if we get any sorts of inflammation, we should remember that CRP is an acute phase reactant. It can be increased. Okay, and albumin can be a negative acute phase reactant, and it may be decreased. Okay, so albumin can be decreased in any acute inflammation as well as uric acid. Okay, alkaline phosphate is slightly increased. Okay, alongside there is ALT and AST, which is in the normal limit. Okay, but urine culture has been done and it shows no growth. So the concern is that what is the most important investigation in this patient? Should you do a anti-CCP antibody suspecting that it's a rheumatoid arthritis or rheumatoid factor or CT whole spine or PSA or X-ray in the both hands? Okay. So that brings me to our today's important topic, that is the RS3PE. Okay. If we discuss about the RS3, it is typically called remitting seronegative symmetrical synovitis. Hence the RS3. The 3S is, it is a seronegative, it's a symmetrical, it's a synovitis with pitting edema. So it is called RS3PE. Okay, it is a remitting condition, and in that condition, the rheumatoid factor must be negative. It must be involving the symmetrical synovitis involving the joints. Okay, and synovitis can be also found in rheumatoid arthritis, but in rheumatoid arthritis, usually in the seropositive cases, there could be rheumatoid factor positive. Okay, so the concern is that it is a distal synovitis involving can be PIP joint or DIP joint, and there must be pitting edema involving the dorsum of the hands and feet. It's particularly more common in old male, and most important issue is that there must be increasing acute phase reactant, but rheumatoid factor must be negative. Okay, so in that condition, the screening for malignancy is so important. Hence, it might be in the backward scenario, it might be a case of prostatic malignancy, as well as the patient is having some urinary complaint. Also, he's having some bone issue. Okay, that there is alkaline phosphatase is increased. Okay, sometimes whenever there is some bone issue, there could be increasing alkaline phosphatase, as we can see in the previous scenario. Just look at that scenario. At that time, also he is having some pain in the localized tenderness in the spine. Okay, alongside there is increasing alkaline phosphatase. So there could be prostatic malignancy having this spine involvement that causes increasing alkaline phosphatase, as well as there is some difficulty in passing urine in the advanced cases. So in that condition, we should do a prostatic specific antigen. Okay, now let's get back to our previous topic. Okay, so in that condition, the screening of malignancy is very important. Okay, so we need to check for important malignancy, particularly prostate malignancy, stomach malignancy, okay, as well as lung, ovary, uterus, hepatocellular carcinoma, GIT malignancy, as well as hematological malignancy, sometimes in lymphoma, leukemia, or Kaposi sarcoma. So all sorts of malignancy can be associated with remitting seronegative symmetrical synovitis with pitting edema. So this is a series of lectures, particularly involving the 7 case. Okay, they mostly describe the 7 important cases and of such condition. In that condition, as you can see, the age is particularly 68, 48, 60, 56. So it's a old age, first of all. Second important thing, though it is the female is also there, but it's mostly common in case of male. Okay, and most commonly the pain is particularly 5 to 8 weeks. Okay, and particularly that involving the joint, that is the metacarpopharyngeal joint, proximal interpharyngeal joint, wrist, elbow, ankle also involved. So the joint involvement is some degree of rheumatoid arthritis. The issue is that there must be diffuse edema in the hands. That's a very common thing. Okay, all the cases having some degree of increasing acute phase reactant, that is the ESR and CRP. All the cases have, as you can see, all the cases as rheumatoid factor should be negative in all the cases. As you can see, all the cases, the rheumatoid factor are negative. Anti-CCP are negative. Okay. And in all the cases, they are giving 15 to 20 milligram of steroid. And after, 4 to 6 weeks, all the patient become pain-free. And the symptoms is improved significantly. So that is the characteristic presentation of this condition. So this is a case reports of 7 cases. The issue is that the current idea of immunopathogenesis is still in dark. Okay, there could be some association of increasing vascular endothelial growth factor, or there's some study about the interleukin-6. Also, there could be some HLA association like HLA-B7, HLA-A2, HLA-DQW2, but these are still not that much important. Okay, sometimes there could be association of some infection like parvovirus, sometimes mycoplasma, even the association of BCG vaccination. The concern is that still the immunopathogenesis is not clear. There is significant response whenever you give a steroid, particularly 5 to 20 milligram. Okay, there's some role of NSAIDs as well as hydroxychloroquine. But conventional DMRT have no role in this condition. There is sustained remission whenever you are giving steroid, particularly 5 to 20 milligram as well. The issue is that there is significant association whenever you are suspecting this condition, because malignancy can be associated with significant amount of cases. In one study, it has shown that almost 54% of cases having significant association with the malignancy. So we should need to exclude malignancy in this case. And nowadays, as the time progresses, Sjogren's syndrome, sarcoidosis, polyarteritis nodosa, okay, there is lot of rheumatological association is also ongoing with this condition. So this is a calibration of some important disorder like the rheumatoid arthritis, the RS3PE, alongside the reflex sympathetic dystrophy, which is called complex regional pain syndrome. So the issue is that in case of rheumatoid arthritis and remitting seronegative symmetrical synovitis with pitting edema, the important differentiation is that it is a sudden onset. Okay, it's mostly involving after 6 decades. There could be synovitis. Synovitis present in rheumatoid arthritis and also RS3PE. But in RS3PE, it's moderate variety. Okay, in case of reflex sympathetic dystrophy, concern is that it is sudden onset, but there is absent synovitis. The significant thing is that in rheumatoid arthritis, there is no pitting edema. In RS3PE, there is absolutely the pitting edema must be common, and which is also common in case of reflex sympathetic dystrophy. Okay, but the issue is that in that condition, synovitis will be absent, and that condition, the response to low-dose steroid will be very bad. Okay, the concern is that in RS3PE, there could be excellent response in case of low-dose steroid. And important thing is that in RS3PE, there could be absence of rheumatic factor. Hence the term remitting seronegative symmetrical synovitis with pitting edema. So that's it for today's session. We'll be back with another topic very soon. Thank you so much.